Good afternoon, fellow Rotarians and guests. I'd like to welcome you to the Rotary meeting of downtown Sioux Falls this Monday, September 28th. We have a great program lined up for you today, so thank you all for being here. In addition to that, we have some new member introductions, which we will be scaling in over the course of the next few weeks, because we do have a number of new members that have joined since the pandemic started and have continued to come in. So we're excited about the two introductions that we'll make here today. We'll start off with the Pledge of the Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. I will now welcome up Rotarian Tony Knorr, who will facilitate today's invocation.
Thank you, President Jason. Good afternoon, fellow Rotarians. So you please bow your head. Lord, bless this gathering of fellow Rotarians today. Please help us to see those in need and give us strength and wisdom to serve our community as we should. Thank you for the opportunity for us to hear from our two amazing health systems today. We are grateful for Dr. Wilde, Dr. Thury, and their fellow frontline health professionals that care for us day in and day out as we navigate this pandemic together. Help us to lift the burdens of others while we maintain dignity of humankind. Soften our hearts to be sensitive and loving as we serve together as Rotarians. Amen.
Before we start today's program, I'm excited to introduce a few new members. I would like to start off with bringing up Jesse Schmidt, who will introduce the first of two.
Thank you, President Jason. Today, it is my great pleasure to welcome back to Downtown Rotary, Sharice Oland. You may recall when Sharice was last with us, she was the president of Children's Care Hospital and School. Following her time there, she and her husband Ivan moved to Wisconsin, where Sharice continued to lead and grow health systems while building her consulting business at the same time. Sharice and her husband moved back to Sioux Falls about a year and a half ago. They are now downtown Sioux Falls residents. They have 3 children, 2 sons in California, and their daughter, Ivy, and her husband, Dave, here in Sioux Falls, who've given them 2 perfect grandchildren. So when she isn't spoiling her grandkids, she is now an adjunct professor at USF in healthcare administration. So please help me in welcoming Sharice back to Downtown Rotary.
Thank you, Jesse, very much for your sponsorship and for your leadership in this organization. It's just extraordinary what you've accomplished this year, and I appreciate the opportunity to return to a group of people that I consider friends and colleagues that had an impact on my life and my leadership in the community of Sioux Falls, in the city of South Dakota, state of South Dakota, and in Wisconsin. Before I start, I just have to say, it is so nice to come back on a Monday and not be badgered by a whole bunch of Packer fans about why I'm a Viking fan still. But I would say I'd hope to make just 2 quick points today because I know we have an extraordinary program. I wanted to say how much Rotary meant to me and when I first began and what it means to me now in returning. But when I first began, I was a young new CEO at then Crippled Children's Hospital and School, 32 years old. There weren't very many women in leadership. And my board was very clear that I needed to join Downtown Rotary as a means of really understanding and learning what leadership was in this community and what the opportunity was that was provided through this program. I will tell you that was one of the best decisions I ever made, because through that experience, I learned from the leaders here how to be a good leader. And I learned that at Downtown Rotary, the programs were always timely, current, important, raised important public policy issues and leadership issues, much like the program we're going to see today. There were only 10 of us women out of 250 members. back in about 1990. So I'm pleased to be back here in a year when we're celebrating the centennial of the 19th Amendment, and to see the growth in the number of women in leadership here. And I hope that we continue as a Rotary Club to fuel that and foster that growth and develop women leaders in our community and state. So I'm very grateful for that. Having returned has been extraordinary. Unfortunately, my husband was diagnosed with cancer and we decided it was time to come home. We'd had a wonderful adventure in Wisconsin, building a hospital, turning around a healthcare system, and doing some things that I was passionate about with my career. My husband, Ivan, is an insurance executive. He's doing just fine. And I always say he had to pay the price for the best decision we ever made. Coming back to Sioux Falls and seeing it 20 years later, 20 years later for me was the last time I stood on this stage as the president of the Chamber of Commerce when we opened this theater. It's kind of shocking. Talk about an old timer. But coming back to our family, where my daughter and son-in-law are now community leaders, and hopefully 2 grandsons will follow their way. And we're pulling back the 2 guys from California to say, you got to come back here when you get your career organized. I have been nothing but honored by the warm welcome and absolutely stunned at the growth and the positive developments in the community. I looked at our plan back in 1999, and everything that we had on that vision back then has been checked off the list, and the vision now is even greater and better. So the legacy lives on. I'm pleased to be back here. Thank you, friends, colleagues, for your warm welcome. And I wish that our Rotary Club continues to do the great things that it's done for me, for every member of this organization. Thank you.
Our next introduction, and this is a fun one, is what, not that Sharice's wasn't a fun one, but this is one that is unique. I would like to welcome up past Governor Dennis Dugard to introduce Laura Mitchell.
Thank you, President Jason. Downtown Rotarians, it's my great pleasure to introduce Laura Mitchell. She is the Vice President of Digital at Lawrence and Schiller. More important to me, she is a great daughter, a wonderful daughter to Linda and me, and the wonderful mother to 3 beautiful granddaughters of ours. And on top of all that, she gave me this excellent haircut. So please welcome Laura Mitchell.
Thanks, Dad. Yes, an unfortunate circumstance of COVID has been that I am now the barber of the former governor. So please no tough criticism there. I must have done an okay job, and now it's mine forever. Yeah, like my dad said, I'm the Vice President of Digital at Lawrence and Schiller. I started there right out of college after an internship. So fellow Rotarian John Pullman in the crowd there. I've worked there since college, so 14 years, but took a leave of absence for about a year to help out on my dad's campaign. So I, along with John, like to take all of the credit for making him look good and also for getting him elected twice. So I'm very thankful to be a part of this group and know a lot of you in the crowd from my leadership South Dakota days, or the Butterfly House board that I'm on, or past United Way, or MB boards that I've been participating in over the years, and really looking forward to getting to know all of you a lot better and being part of, involved in a lot of the initiatives that you guys are working on. So thank you.
I'd like to bring up all of the 4 of them to take a picture and to give you guys a welcome packet.
Thank you.
Reese. Laura. Like, Thank you. I would like to now introduce Dr. Paul Ahmanson, who will be facilitating today's important discussion with representatives from Avera and Sanford. It is no secret South Dakota is privileged to have two prominent healthcare systems, and we are very fortunate that those two healthcare systems are doing proactive and measurable steps to improve the safety and livelihoods of all of the citizens of Sioux Falls and the surrounding area and region and country. Dr. Paul Ahmanson, I'd like to now turn it over to you to facilitate today's conversation and to introduce our panel.
Thank you, Jason. Hopefully you all can hear me fine. First of all, welcome. Thank you for coming. This is a talk I was probably hoping I'd never have to give regarding a pandemic in our lifetime. Author John Barry in 2004 wrote a book regarding the great influenza that described the impact of the 1918 pandemic on the world. The impact on deaths in the United States during that pandemic was roughly just shy of 700,000 people. So far this year in the United States, we have had approximately 200,000 deaths from COVID-19. This would make it approximately the third leading cause of death if no one else died this year from COVID. To try to put it in perspective, it would be the third leading death following cancer and heart disease. I am joined today by two of my esteemed medical director colleagues, Dr. Chad Thury from Avera Health, who serves as medical director for quality, and to my far left, Dr. Mike Wilde from Sanford Health, vice president and medical director for quality as well. I'm sure you're all aware that we are all three physicians. Our backgrounds are in science-based theory. There's certainly been lots of information spread, some very accurate, some highly inaccurate. And our background in science is to look at data, analyze it, and try to make the best medical decisions we can based on scientific information. So saying that, we expect to have a lively discussion. Unlikely will we have time for questions at the end, given the breadth of the topics that we expect to cover today. So I'll start with Dr. Thury. One of the things that we'd like, I think, to hear from both health systems is what is the current state of affairs within the health system related to COVID-19, specifically as it relates to hospital levels, ICU capacities, not only within Sioux Falls, but also within the entire region that's impacted by your respective health systems.
So, well, thank you very much, Paul, for having me here, Rotary. Thank you so much for having us. I think this is a great topic and will be a great discussion. I guess first off, I'd just like to say that I am a previous Rotarian, past president at Rotary South, so it's great to be back here, and Rotary certainly has a place in my heart. Most of you may know me because of someone that you know more, and that's my wife, Bobby, who's here. And so she is now a Rotarian here, which last week when we were talking about this, she said she was trying to become a Rotarian. I told her hopefully my performance here does not impact that. But once again, thanks for having me. As far as how Avera is doing, we are certainly doing well and holding our own. And we've been planning for COVID for a number of months now, and we have our surge plans in place, and we are implementing them throughout the system. You can tell from the South Dakota numbers. If you look on the South Dakota website, our incidence of COVID is going up. If you compare it to back in the spring, we're double incidence on a daily basis. Our 7-day averages and so on is going up, and it's going up rapidly. You don't have to go back very far, i.e. the end of August, early September, and we were kind of just hovering around about 60 cases, 50, 60 cases in the state every day. And it's really taken off here. And so we are seeing that in our hospitals as well, so increased hospitalization rates. And if you look at the state numbers, again, probably double or more what they have been, even going back to the spring and throughout the summer. And hospital beds, we're still doing well as far as availability throughout our system. Avera is busy all the time, and certainly this time of year with people trying to get planned procedures in before the end of the year. They've met their deductibles, that type of stuff. And so we kind of already have this increased need this time of year, and then you add COVID on top of it. And so Avera, as far as being a region of 37 hospitals and stuff, we have the ability to kind of use that system to the best of our advantage. So we have a transfer center that helps navigate kind of like the flight people in an airport, so they're navigating where do we have availability for a bed, and where's the best place for that patient. And sometimes everybody thinks that they have to come to Sioux Falls and that's the best place, but that's not always the case. We have great doctors, we have great medical staff, nurses and so on throughout our regional facilities or critical access facilities. And so sometimes going from a critical access hospital to Sioux Falls is not necessary. And so we'll send them to wherever those patients need to go within our system to try to keep those beds available that we can throughout the system. And so we continue to work on our surge plans. We continue to meet on a regular basis and have communication with the state and other health systems as far as how do we handle the increased needs that COVID is going to be bringing to us here over the next number of months.
Thank you, Chad. Mike, same question to you with emphasis on hospital capacity.
Sure. And I'd also like to start off by thanking the Downtown Rotary Club for having us and your engagement. This is good that people in healthcare, leaders throughout the community are interested and supportive of what's going on, what we're doing. And I can tell you that the companies you represent have been very supportive of us in regard to taking care of themselves, taking care of people, listening to the message. And sincere thanks to the folks of this region, very intelligent people who have heard the message. And like Dr. Thury pointed out, when this pandemic started, it started off in an unusual way across across the world and then across the country in some really tough circumstances. And like anything else, Dr. Ahmanson alluded to influenza. We have familiarity with that, where eventually it does make its way to the upper Midwest. And we saw that earlier in the year, and now we're seeing it again as expected as kids return back to school, as we see a little more traveling and things of that nature. You start to see more outpatient cases, which is going to translate into inpatient cases. That being said, we're still at a rate of COVID that is very manageable, but on top of that, we see surges and troughs in patients needing care on an annual basis. And typically around this time of year, we do start to see some increased need for hospitalization, whether it's due to people going back to school or getting more off that summer vacation and back into work. And there tends to be a little uptick of hospital need anyway, and then in the setting of this pandemic. So we too have physician-directed communication where we work with our outlying facilities in addition to Sioux Falls and moving patients through and trying to prioritize those with highest need, or those are really, our goal is always to take care of patients closest to home. And so we have conversations, patient-centered conversations about where would be the best place for this person to be cared for and what makes sense. And then we try to move patients, whether it's appropriate to move them to Sioux Falls and then back out to a facility close to where they came from if that's necessary. We certainly have always worked with surge and surge capacity and best practices where people should go in those situations, and we're operationalizing that at this time. So while we certainly do have inpatient capacity in addition to ICU capacity, we're running at a level that is more in that surge type. And so we're working with patients and outlying facilities to make some decisions to best care for patients where it's most appropriate.
Question to both of you. If you look at certain national reported numbers, and I think we all can agree that there's some lag in when positives are reported versus when they're actually tested and done. South Dakota and North Dakota appears to be leading the country in number of positive cases per 100,000 individuals. The question then is, what, if anything, are your healthcare providers seeing at the people who are sick now? Does it seem to be people that are primarily we're able to treat as an outpatient? Are the people that we're treating inpatient as sick as they used to be? Comment as well as you can on some of the newer treatment modalities that we're finding that seem to be effective in reducing the morbidity and mortality or death of people with COVID-19.
Well, I think to start off with, kind of like what Dr. Wilde said, we are in a part of the country where COVID and influenza, when that comes and has come, we get a little bit of foresight as far as what's going on. So as we all have seen, cases tick up in other parts of the country, and then it kind of moves us away, and we just happen to be at that point in time where things are surging here in South Dakota and the region. So we got to take that on as it comes. I think one of the things that we hear about, and going back to schools opening, colleges opening, younger adults seem to be driving a lot more of the spread here as far as COVID goes. And that does somewhat bode well as far as they're less likely to need medical intervention, less likely to need hospitalizations, and so on. But like you also said, there's a lag. So when they become infected, they potentially spread it to other people that spread it to people that ultimately do need to be hospitalized. And that's when we start to see that impact from a medical standpoint, going back to capacity and ICU beds and stuff like that. So although maybe the demographics have changed as far as who's becoming infected, we're starting to see that trend coming up. That impacts us certainly from a clinic standpoint. Those people that are becoming infected or having symptoms, they want to, for the most part, know if they have COVID, and so that drives increased demand for clinic visits within our health system. We try to do as much as we can through virtual visits to try to mitigate spread within our employees and staff and stuff like that. And that also drives testing, which I think we're going to talk about later too, and the increased demand for testing. So we continue to work on all of those things as far as that's spread of COVID. As far as outpatient, I'll just comment on that now, but outpatient, there's really nothing that we have to treat COVID. Pretty much all the treatments that we have are directed for inpatient patients. So.
Yeah, I would agree. And some additional information, I think what we've seen with this latest increase in hospitalizations has been an older age compared to where we were before, in addition to those what we call comorbidities or other existing illnesses that can put people at risk. And, I just personally think of like my father-in-law a couple of years ago, not in this area, but certainly had illness on top of a couple others. And we always just said, if any of us or the grandkids are around him and they're sick, they can't be around him. And the same goes for COVID. And that's really, I think what we need to focus on is if you're not feeling well, or if you're in that age group that's at older age with medical illnesses, that's probably be most attentive to what's going on right now, as should be with any other upper respiratory infections. While a lot of us can do just fine with that, there's others that will not do real well with those types of things. And that's really the population we're seeing now in the hospital. However, what we have seen, as we've learned internationally, nationally, and within Sanford, weekly conversations with our intensive care unit physicians and our primary inpatient physicians is really sharing those best practices. There has been progress made in terms of trying to keep people off ventilators and things like that. And we are seeing some results of that, but unfortunately, People still do require those cares from time to time, but we have seen some advancement, obviously not a cure, not a home run, but certainly good progress with some of the medications that we were using to treat COVID, and certainly use those as appropriate within the hospital as well.
Thank you. Help us understand how both health systems protect, the measures you take to protect patients as well as your employees, especially those employees who are on the very front line of essential health care.
Yeah, so Avera, we have a mandatory masking policy, so that's not only for our frontline workers that are face-to-face with patients, but that's anybody that's back end and so on. So we need to keep
regardless of where they work.
Regardless of where they work. So so within our business offices and so on, it's mandatory masking, and really we need to have a healthy workforce and a safe workforce to be able to operate. From the standpoint of clinic-facing employees, and then within the hospital setting, you know, that it's being cognizant of the situation and then wearing the proper PPE that meets that particular instance. So if you're directly working with a COVID patient, it's going to be a higher level of PPE. If you're in a clinic setting, it's, you know, bare minimum of mask and face shield for protection. And then we also require that our patients come in when they come into the office setting or into our facilities, that they wear a mask as well. So we want to protect them as much as we want to protect ourselves as well. And so that's kind of the policies and procedures that we've put in place to keep our staff safe.
Same, I assume, from a patient-directed standpoint as well. Do you require people coming into the facilities to mask as well?
Exactly. Yep. So whether it's patients coming into the facility or if it's vendors that need to do anything on our campuses or clinics, we require masking.
Okay.
And then the other part of that I should say is that we're also screening. So we screen our employees for symptoms and temperature, as well as patients that come in or vendors that come into our facilities.
And Mike, if you could comment as well, since Sanford has a very close relationship with the Good Samaritan Society, you know, a very broad long-term care footprint throughout the United States, if you could comment similarly.
Yeah, I think the first step we did was really educated ourselves and our fellow employees in regard to the spread of this pandemic and what makes sense from a personal protective equipment and measure standpoint. And so we really try to distance our employees. We've put up, just like you see in a lot of retail, many of you have led as well, the plexiglass barriers, things like that, in addition to masking, and just really focused on that hand hygiene. And I think Dr. Thury had alluded to earlier, or it might have been someone else at a different interview, sorry, but really in the areas where you could perhaps let your guard down, socialize a little bit, like the break rooms, things like that, those can be areas of vulnerability also. And so just educating so people can be thoughtful, and then really learn best practices as Good Sam and that part of Sanford is in 26 states, really learning what has been seen, because as I alluded to earlier, you know, we see infection in higher in different areas. What are the learnings from those areas? What steps were taken? What makes sense? And what makes sense for us as an organization based on those learnings? And obviously there's been pretty intense federal and then state regulation in regard to isolation of long-term care facilities, knowing that that's a very vulnerable population, and working within that, and how if there's any best practices that could be shared throughout all of Sanford, and certainly awareness as to what's going on just outside of this region. It's been a very valuable relationship and good learnings from that.
What changes are you seeing within your own health system and how healthcare is delivered that you think is short-term versus some long-term changes that more likely to change some internal systems for providing care directly to people, both inpatient and outpatient?
Yeah, so I think one of the big changes that we see both right now, short-term, and we're living it, but also going to be able to expand upon it, is going to be virtual care and telehealth. I mean, so going back to my comments about trying to treat patients that maybe have COVID outside of the clinic through virtual care, but also using that virtual technology for specialists within our system to reach out to, more rural areas. So for instance, when it comes to our infectious disease consultants and being able to have those clinic visits with patients outside of McKinnon, which is, the place where we have our infectious disease providers. And so that's going to be a big thing going forward, is now that insurance companies are starting to reimburse for virtual visits, and how do we use those to our advantage going forward, not only now, but how do we make that opportunity more efficient for our healthcare systems as well, to improve quality of care, decrease costs, that type of stuff. So I think virtual technology is another thing. The other part of using virtual technology that we've used at Avera is also through our Avera Home front. And so going back to hospitalization topic, but also virtual technology, this is kind of a perfect mix. But a lot of uptick that's been happening lately throughout health has been kind of the hospital at home model. And so we've got into that with the pandemic, and the fact that we have patients that are tested positive for COVID. They're maybe high risk. They have the comorbidities like Dr. Wilde was talking about. And so we know that they're more likely to end up in the hospital, and they need to have some education along the way. And so we can get them enrolled into our Avera at Home program. We can get them an oxygen monitor. We can get them oxygen in their home. So these are patients that are being treated at home through virtual technology, virtual visits with our providers, using digital software to communicate through chat functions, monitor vital signs, that type of stuff. And so we are, preventing hospitalizations and allowing increased hospital capacity because of that type of technology that we've put in place because of COVID. And that's something that we can expand even outside of COVID as time goes on.
Limitations in our current technology that would limit some of the increased advances in telehealth or care at home?
I'm not sure how much limitation there is in the technology. There's maybe some limitation from the standpoint of reimbursement. So not a lot of insurances really at all, pay for hospital at home service. It's more of, can it save, the system money in some way, or can it open up hospital beds for somebody that needs a higher level of care at this point in time?
Mike, same question.
So I'll go back to the first question, which was around short-term effects of care during COVID, and then long-term. Short-term, and I'll start kind of negative and move more toward the positive part, but short-term has been, just by nature, that delayed diagnosis, delayed care, and ramifications of that. And that's probably part of the influx of patients that we're currently seeing is patients need care, and they're going to seek us out for care. And you can't delay things forever. And people have done a good job trying to get in when they need to get in. And so we're seeing a little bit of that, and that we'll move on from that. And patients have been very respectful and doing a good job of seeking care as appropriate in a timely fashion. They're certainly getting back to that. I think long-term, we are going to see, we've seen a slow adoption. We have a lot of technology available, whether it's, as Dr. Thury alluded to, we have the chat functions, we have the e-visits, and then we have telehealth as well, where on a screen you can communicate with a physician or an APP as a PA, nurse practitioner, as appropriate. And I think that's exciting things. I think that's a good for patients, no longer driving 100 miles to come in for a visit, and rather getting that care where it makes sense for you, close to home. And certainly I think there's some legislative action that needs to occur to continue to assist with that. But being spread out across the upper Midwest, I think that's an exciting advancement that really was prioritized during this time of pandemic. I think there is some bandwidth, or it's me trying to do IT, so it's not going to go real well, but some connectivity issues. And then we're really working at Sanford, as we've identified, there's a lot of kind of startup apps out there to provide that technology for online visits. And we need a better platform, kind of a more standardized way of doing that. And we've identified some technology that we're trying to roll that out to a lot of our clinicians, kind of a one platform. Here's how we best do it, and get that optimized and get people comfortable with that, because we're all used to that technology. And under the crucible of COVID, we started using quite a bit of that, and I think we can do that a lot better and try to really meet the patients where they are and best serve them that's close to home.
You both have quality in your titles. And I'll hearken back to the days being on call when I would take a phone call from a distraught mother in the middle of the night with a child with fever, and they would demand it almost to be on antibiotics because they were sure that their child had an ear infection. We always felt uncomfortable handling things over the phone because you could not examine the patient. There were many things that missed out on that face-to-face conversation. So how do you maintain high-quality healthcare that's expected in this day and age with more virtual type technologies? You know, where's the balance point there?
Yeah, I mean, that's a great question. And, you know, what we are doing at this point in time is we are identifying through our service lines, you know, our 13 plus service lines, as far as what are appropriate things to treat and see when it comes to virtual technology. And you know, even historically, we as a system kind of push virtual care as more of an acute care option, you know, going back to the ear infection, strep throat and stuff. But really, you know, it can be a great tool for chronic disease management. When it comes to being able to listen to somebody's lungs, to be able to look in an ear, look in a throat, there are tools out there such as title kits, which can allow providers to have access to look at those things. But you know, patients need to have that, you know, at home to be able to do that, or have access to that type of equipment to do it. So I think it comes back to we need to fine tune some of that access to some of the title care type products that are out there, but also, you know, being able to use virtual care in the appropriate way.
Yeah, I'd agree with that. We've obviously had a great relationship with Title Care, and there's amazing technologies out there for like the Title platform to assist with the online type visits. During the spring with COVID, in talking to our primary care clinicians, they certainly could do a lot of the care online, but it did reach a point where sometimes you just need to sit down face to face with a patient, listen to them, do the proper exam. And so what we're learning from across the nation is there's certainly conditions that really do lend themselves quite nicely to an online platform. There's some that most of the time will, but at least once a year, or if not more often, you do have to have that face-to-face kind of check-in with a clinician as well.
Let's move into testing. Personal disclaimer, CVS Health, the company I work for, performs approximately 5% or 40,000 COVID tests a day. Interested in COVID testing within the individual health system, specifically as it relates to ability for individuals to access timely and accurate tests, as well as any limitations on testing related to potential reagent or other testing equipment shortages that may or may not be within areas of your health system.
Sure. So, yeah, testing is one of the things, like you alluded to, that it's not just the test that you need, it's a lot of other factors that you need. So you need to be able to have the reagent, you need to have a swab to do the test, you need to, for some tests, you need to have this little brush that you use. And so you have to have all those pieces in order to run that test. And, you know, we are at the whim of companies that manufacture that stuff. And so our supply chain team does a great job of trying to accumulate those, and we've done that throughout the summer to put ourselves in a good position when it comes to testing. One thing that is also nice is that I think the end of last week, Cepheid, which is a company that makes a rapid test that we can use within the hospitals and clinics, much like we've ran our previous influenza and RSV tests on over the last number of years. That they got an authorization to start that. It's called a 4-plex test, so it can check for COVID, influenza A, influenza B, and RSV. And so that should hopefully, as that rolls out to our facilities, increase our testing capacity. But where we were sitting, you know, as we went into August and early September, the increased demand recently for testing has, as you know, has gone up. And so the supply manufacturers and stuff are trying to keep up with that as well. And we just keep looking at all of our sources as far as getting those testing supplies that we need. And then also we try to kind of diversify our testing platforms. And in case one company is out, we have some excess with another testing platform as well. And then really trying to focus on the testing guidelines that we set out for our clinicians, who should be tested, what's the appropriate test, and then what's the appropriate platform to run that test on as well. So those are all the things we look at when it comes to testing within our system. And we have a testing committee that meets on a weekly basis to kind of review those things and make sure that that information gets disseminated out throughout the system.
Clarification, the fourplex test that checks for influenza, RSV, and COVID, is that a quick turnaround time?
Yeah, so that is a Cepheid machine that is a quick turnaround
Okay.
time. So that, going back to your point of sometimes if we run into testing limitations in what we can run, at Avera proper, then sometimes we have to send some out to regional labs. And so this is going to increase not only the turnaround time for some of our testing within Avera, but certainly decrease the number of tests that we would have to send out at times. So.
Yeah, I'd say it's been kind of an interesting part of this whole pandemic is the amount of testing. I think we have, both health systems have really prioritized that, but at the same time, it is the swab in the nose, it's the reagent that the sample goes into, and it's the machine to run it on, and it's having the technologists to operate the equipment. The rate limiting step right now really tends to be that reagent that the swab goes into, and that does tend to be on a federal allocation. And so we don't have a lot of control over that. We've had a reasonable supply. We certainly have a reasonable supply of that quick turnaround type test, which we prioritize to those most in need, like our ERs or inpatient facilities. And then we have, through the drive-through, a little different platform of technology, which typically within about 24 hours we'll get those results back. At times, in times of high need for testing, we will work with outside resources as well to send some of those tests out. And so we certainly have really worked on a daily basis with our supply chain team, our lab experts to try to stand up the best testing, best access as we can.
Comment briefly, Mike, on accuracy of the test. Are you comfortable with the accuracy of all of the platforms that are being used within Sanford? And if so, what recommendations are currently being sent out to your providers for testing of asymptomatic individuals or people who may have been exposed to somebody with COVID, but they aren't exhibiting any symptoms? Because I know the FDA has been a little bit waffling this past week on recommendations on that.
Yeah, good question. So what we've done at Sanford is we have prioritized what's called a Pcr test, which really tries to take some viral particle and amplify that, so you don't need a lot of virus, if you will, on you in order to get a positive test. And that's what I think of as a gold standard technology. There's some other technologies out there. This one is felt, in our opinion, to be the most accurate for a medical facility. I think it does have a reasonable, what we call sensitivity, so that if you do actually have the virus or the illness, it will be detected. It does lead to issues with the asymptomatic testing, asymptomatic positives, where you test people, you don't think they have it, and they actually do. And that can be sometimes the issue with a high sensitivity. We still are wrestling, just like I think everyone is, in regard to do you test patients with after they've had exposures, or if they're going to have what we call an aerosolizing generating procedure, meaning a surgical procedure where they're placed on a breathing machine and you got to get that introduced into the lungs, and that can put people at risk because there's that's what's called an aerosolizing generating procedure. Aerosol generating procedure. And so there's we're wrestling back and forth. Basically, we look at our testing capacity, testing need. Should we continue to be testing asymptomatics? As we know from guidance from the Centers for Disease Control, even if you've been exposed, you can't necessarily test your way out of quarantine. And so why would you bother testing? Well, then, some compelling circumstances can come up from time to time. So it's always a kind of wrestling with some unclear or moving guidance, exactly how to go about doing the testing in the setting of limited resources from that standpoint.
Mike, you brought up the term federal allotments. There have been federal allocations for specific therapies such as remdesivir, which was FDA approved through an emergency use authorization for use in more critically ill people. Interested in each of your health systems' approach to using therapeutics, whether it's hydroxychloroquine, convalescent plasma, steroids, remdesivir, which I just mentioned, and potential for use of monoclonal, polyclonal antibodies.
Sure. So, yeah, I alluded to earlier our clinical group that we get together across Sanford. Plus, we've had WebExes with other organizations across the country, really lifting up those best practices, staying very in tune with the literature, and things can kind of get pushed into, you hear stories and conversations, and as Dr. Ahmanson alluded to, we're scientists trying to manage a pandemic right now, and so you really try to look at the best medical literature, and I think all of us would agree medical literature is not a fast-moving thing, and we've known about this illness for literally less than a year, and in the setting of medicine, that's not a real long time. And there's been tremendous evolution in where we've gone just in that time. Right now, it does appear that we do use medications like Decadron, which is an anti-inflammatory medication. In the appropriate populations, we are using remdesivir and do have a good supply of that. In addition, we'll use convalescent plasma, and then we're involved with several research trials with really kind of thinking of them as like an anti-inflammatory type medications, because that really tends to be where the most vulnerable can get very ill from COVID, is just that immune response where their immune system really gets activated to causing quite a bit of inflammation. And we have medications that we use for other illnesses and indications, and would those work in the setting of COVID? And those are some of the trials that we're currently doing. So we're very open-minded. We have, like I said, we really work with our own experts internally and externally as well, trying to provide the most recent treatments as appropriate.
Yeah, I would agree. I think, what I've learned from conversations with our hospitalist team and infectious disease doctors is that Decadron or dexamethasone has been a really good treatment for inpatient setting. It's been shown to decrease mortality, which is a good thing. It's cheap and it's been around for a long time, so we all have a lot of familiarity with treating with dexamethasone. Remdesivir, which is the antiviral that has the emergency use authorization, we once again have not had any limitations as far as treating patients with that based off of supply. It all comes in through McKinnon, and then we work with our infectious disease team, e-hospitalists, our e-pharmacy group to administer that even in our rural settings, so we can treat patients no matter where they're at within our healthcare system. And that's the nice thing with that is it's been shown to decrease the duration of hospitalization. So we talk about our hospital capacity, and the faster you can move people through your hospital, the more beds that open up. And so that's been a nice thing too. Convalescent plasma, we continue to be in trials with that, and it does have emergency use authorization as well. There's probably some improved symptoms with that, but I think the jury is still out. One trial that Avera is doing now, it's actually kind of a three-pronged trial, but it has to do with what's called a monoclonal antibody. So with convalescent plasma, you're basically taking blood from people that have had COVID, and then you extract that, you get the plasma portion of that, and then you give it to somebody that is sick with acute COVID infection. And so the antibodies that other person has built up, you're administered to somebody else, hoping that decreases the inflammation and stuff. So monoclonal antibodies are kind of taking the one or two very specific antibodies that can attack the COVID virus and seeing if that's more effective. And so we're looking at a trial where patients are in a random double-blinded trial, and whether you're in the hospital setting, so that could be one arm of the trial. The other one is hospital COVID positive patients. The other one is outpatient COVID positive patients as well. So do the monoclonal antibodies decrease symptoms? Do they decrease the duration of illness? Do they prevent hospitalizations? Do they prevent mortality? That type of stuff. And then the third part of that trial is looking at people that have been exposed to COVID. So if we administer that medication, does it prevent them from getting COVID as well?
So from what I gather, treatment availabilities are primarily still focused in research on the inpatient level of severity, although I'm hearing that some of the early trials that are going on are starting to move into more of the outpatient levels to try to prevent people from getting hospitalized, getting that sick. Is it a fair statement that even in the relatively short period of time, we're doing a better job of treating the people who are inpatient, that those, perhaps the mortality rates are going down of the people who are hospitalized? I know it's a tough question because, these are typically older people with more comorbidities.
Yeah. And I think that goes back to what I was talking about earlier, just, even alluding to my father-in-law. It's some people are going to get ill and there's not a lot you can do. And it stinks that it's COVID. It could be really anything else. There's some vulnerable folks out there, and there's, you can try some of the treatments. They're probably not going to be all that effective. There's other populations that come to us with this illness where those treatments can be really quite effective and have seemed to make some progress in regard, especially to intensive care unit admission and mechanical ventilation.
I'd like to talk a little bit about vaccinations. I know I could have a full-time job just following all the studies that are going around the world in vaccinations. And we know there are hundreds of vaccine trials going on around the world, some front runners, at least in the United States. The earliest expectations are at least one to be available through emergency authorization by the end of this calendar year at best. Phase 3 trials that are going on probably won't be completed for another 2 years, even though emergency authorization would allow use prior to that. Please comment on your understanding of allotments of vaccinations that might be available to your health systems and how you will prioritize the administration of those limited supplies.
So I think, sorry.
Go ahead. No, go ahead.
Yeah. I'm on a weekly call, really with a lot of healthcare providers in the state, with the state health department, who's in close contact with Centers for Disease Control. A lot of this is going to be federally allocated and directed in terms of supply and then who gets it first. I would just point out, I have not heard any sort of political statement about trying to rush it or trying to, so it's all about really getting it out to who we think it's most appropriate in that first wave and then progressing from there. It's kind of an interesting time that we haven't seen in medicine, where while the vaccines are being studied and trialed, they're actually being mass produced. And so that's part of what Dr. Ahmanson was alluding to in that emergency use authorization. So we anticipate perhaps even toward the end of October, first part of November, or perhaps a little later, having some within each healthcare system getting vaccinated. And there's still a lot of questions that need to be answered from that standpoint, but vaccine is coming. It's not going to be an immediate fix to the situation, but it's going to be part of the progress, I think, toward an eventual fix of the situation.
Jenny?
Yeah, I would agree with that. And from the conversations that I've been part of, it's regular meetings with the state, it's communication with the health system, so we're all on the same page as far as what we're going to do, because like Dr. Wilde said, it's going to be federally allocated to South Dakota, and then South Dakota is going to hand it over to the health systems to administer to the population. And so when that comes, we don't know, but we're planning and preparing as if we're going to get it on November 1st or around there. So we are trying to shore up our supply chains and make sure we have everything in place so that we can do that at the time. And also, as he alluded to, it's generally going to start with those that are at highest risk of at getting COVID. So, our frontline healthcare workers that are working in those situations, and then probably the like long-term care facilities and congregate settings and stuff like that that we'll have to focus on initially. So, like you said, for young adults and kids that are otherwise healthy, it's probably going to be a while before a vaccine gets out to them.
I've heard the term lately, vaccine hesitancy, and it has two parts, I think, right now. One is there's going to be a relatively low bar for emergency use authorization, I think, on the first vaccines out of the gate. At 50% efficacy is the bar, which means it's going to work in about half the people it's administered. How many people do you think, once it's more available to the general public roughly this time next year, do we think are going to be comfortable and trustworthy of that type of vaccine? And then now, as we're starting to move into the flu season now, are we concerned about hesitancy of people to be vaccinated in general? I even read last week about Medicaid rates of childhood vaccinations having gone down roughly 20% since March for various reasons. But to us, I think that's a mainstay of public health, is vaccinations to prevent infectious diseases.
Yeah, I think, historically there's been, a subset of people that are just not interested in vaccinations for whatever reason that may be. And now when you start to talk about, an Operation Warp Speed, where we're trying to do something faster than we've ever done it before, there's people that are going to be questioning that process and what's the real efficacy of the vaccine, and are there any harms, and is it safe for the public? And so, like Dr. Wilde said, those facts of the scientific data is not going to be shown for months and months down the road. And so part of this vaccine campaign is going to be hopefully ensuring to not only our employees but people in the public that it is a safe vaccine and that it is efficacious. And hopefully when these vaccines start to roll out, that data is available for not only us as providers to stand up on and make that claim, but also as people that are getting the vaccine to feel safe that they can do it. And I think that's going to encourage more buy-in for vaccinations. And you go back to vaccine and we kind of talk about herd immunity, and that's with any type of vaccine, but we think you're going to need 60 to 70% of the population either vaccinated or previously infected. So that's some type of immunity to hopefully get back to some semblance of what things were like prior to COVID in our lives. So that means there's a lot of vaccines that need to be administered over the next year or so to get to that place. And so we need to be confident in the safety and effectiveness of those vaccines, certainly.
We have a limited time left. Dr. Whitley, I'd like to give you some final time for thoughts and final recommendations you can make to everybody on things that they can do personally as well as maybe as a company to help to keep themselves safe and healthy.
Yeah. First off, I'll just start with the vaccine area, and certainly as employers or leaders, if you have the opportunity to promote flu influenza vaccination, that's a really good idea, especially in this time. And we certainly we mandate it within our employees, and just feel that's a best practice to lift up and want to encourage that. Advice that I've learned, physician trying to do HR and employment things is not always a good thing, but certainly I've learned from some great leaders at Sanford is just really having those HR policies in place as an employer, because there's things beyond our control, and not from just there's CDC guidance, there's health department guidance, as there should be, on when to quarantine, when to isolate, for how long. There's not a lot you can do about that, including testing. So it's really about, hey, if you have a couple of employees that have to that have to watch after some kids at home because they can't be in school, because, how are you going to work with that? Kind of trying to think of those scenarios, and certainly want to have people very thoughtful of those type of situations that they're going to encounter, and many of you, I'm sure, already have. And then lastly, as I started with, thanking people of this region for their continued efforts to stem this pandemic. They've done a good job. People have been getting it. It's not because they failed. It's, it's out there. It's ubiquitous. And that's probably the best way to think about this from an infection prevention standpoint. We're all sitting here wearing masks, trying not to touch things. Hopefully all of us will kind of douse with hand sanitizer as we walk out of this great facility. Not that it's the facility, it's the pandemic. And so as you're out and about and around, be very conscious of what you're doing. And it's not just masks, it's not just hand hygiene, it's not just staying away. It's really kind of a combination of things like that. What makes sense for you? Are you one of those folks that has some illnesses and is pretty vulnerable to becoming very ill from this? Then really have some thoughtful reflections with yourself in regard to, should I be doing this? Shouldn't I be doing this? And being proactive from that standpoint, but also just thinking about what you're doing out in public. I think it's perfectly fine. I think it's a good thing for people to get out. You can only stay in for so long, so it's a good thing, but really be thoughtful about, does this make sense for me in the moment? And what have I touched? What am I doing? How can I mitigate this by using some hand sanitizer, going washing my hands, staying away from people, whatever you need to do. It's just that continued thought, and the people of this region are doing a good job.
Thank you. Chad, final thoughts?
I mean, I would echo that as well. Number one, get your flu shot. Very important. We want to try and decrease the impact of influenza as we go through the fall and winter months. I agree. I mean, there's things that have changed over the last 6 months. There's things that we've learned, but kind of the tried and true thing is social distancing, hand washing, hand hygiene, and then face masks. You mentioned the vaccine and kind of the low bar initially for efficacy, and that's about 50%. There's something that you already have, and everybody here is pretty much wearing it, that decreases the transmission of COVID by 50%, and that's wearing a mask. And so we can do that every day, and the more we do that and continue to do that, from a business standpoint, your employees are going to be at work, your kids are going to be in school, and we're going to be operating as normal as we can. So I think just do what we know to do and keep doing it well.
Well, thank you, Dr. Chad Thury of Avera Health, Dr. Mike Wilde, Sanford Health. We thank you both very much for sharing your expertise and thoughts and recommendations with our group. Unfortunately, we're out of time, so I think I'll call our president, Jason, back to the podium. But again, thank you all for attending today, and stay healthy and stay safe.
Dr. Thury and Dr. Wilde, thank you so much for joining us here today for a thoughtful and unfortunately timely discussion. There's so much information flying around, and it's often tainted with a political bias. So it was really refreshing to hear this science-based conversation for the Rotary members as well as the larger community that is viewing our programs. Thank you. Next week, Monday, October 5th, we will begin our election series. The first of that series will be, Should Marijuana Be Legalized in South Dakota? The programs and the meetings will be held at the Holiday Inn going forward. The Holiday Inn Falls Ballroom on the first floor. We will be practicing social distancing. We will have lunch provided, but it will be following strict social distancing guidelines. Fellow Rotarians and guests, I want to thank you for joining us today for this important conversation. Please also tune in to, in the email that you received this morning, there should have been a link to the Rotary Mentoring Moment. And we do want to thank Jim Berman's team at Dakota News Now for producing and airing the spots. On last Thursday of each month now at 10 o'clock news, we will be having the Rotary Mentoring Moment. Thank you all. This meeting is adjourned.